Well, hello everyone. It's such a pleasure to be here in person with you, our distinguished panelists. And for all of those who are joining us in person as well as online, we welcome you. We are excited to continue the summit and to dive into this very important topic. So the topic of our session today really is focused on how providers and both physicians and non-physicians can help to bring about health equity. And we're going to do so through the lens of narrative. But I would like to start first by allowing our panelists to briefly introduce themselves, starting first with Nikki.
Hey, all right. So good afternoon, everyone. My name is Ranika Alexander-Parrish, and I'm the U.S. Medical Director for Health Equity for vaccines and antivirals with Pfizer. And my role is related to medical strategy and making sure that all of our health equity work relates to our patients' equitable experiences and outcomes. So excited to be here.
Thank
you. Good afternoon, everyone. My name is Dr. Gilbert Burgos. I am the Interim President and Chairman of the Board of the National Hispanic Medical Association. The NHMA, as we call it, is an organization that's been around for 30 plus years, primarily focused in supporting the interests of Latino physicians in the United States as well as the Latino communities that we serve. And I'm very, very happy to be here today representing them and discussing the issues that we're going to be discussing very shortly. Thank you.
Hi, everyone. My name is Chen or Chen squared. Very nice to meet everyone. I am here on behalf of the Asian American Pacific Islander Nurses Association, or PINA, and we represent the interests of Asian American nurses across the globe, making sure that we help advance health equity in that lens. In my day job, I am a national level chief officer for the public sector. So my disclaimer is anything I say today has nothing to do with the public sector. Right. It has to do with me as a human being, Chen squared. Thank you.
Good afternoon. My name is Dr. Yolanda Lawson. I am the immediate past president of the National Medical Association. I served as the 124th president. We were formed in 1895. I'm proud to say I was the 15th woman to lead the National Medical Association. I have a lot of jobs. A few of them are listed. I'm also the medical director for Abounding Prosperity. That is a community-based organization in Dallas. It sits in a medically underserved area, and we primarily deal with HIV disparities. That zip code has one of the highest rates of HIV in the entire metroplex in the state. Again, a lot of jobs, but I'll stop there.
Yeah. Well, I'm sure we'll be able to learn a bit more about those jobs. And I actually neglected to introduce myself. So Walter Conwell, I primarily serve as the Chief Diversity and Inclusion Officer at the Morehouse School of Medicine. I also have the privilege of serving as the Dean for Faculty Development. I'm a practicing pulmonary, critical care, and sleep medicine physician. So we're going to start with our first question, really focused on personal narratives. If you can share with us a bit about your personal narrative and how you use your personal narrative to make an impact related to health equity.
Thank you for that question. I think our personal narratives are so important. That self-disclosure, that vulnerability, it's so important for patients to see you not as this person or this entity that is so much different from them, but someone that may be just like them. I am a nurse by training. I started out as a public health nurse working out in the field in my very own neighborhood. So I would go out and see pregnant and parenting women who were very close to my age at that time. I'm past that age now. But they looked like me. We had the same community. So I was able to talk to them and understand what their challenges were. I grew up, of course, well, not of course, but in Flint, Michigan, a city that people maybe heard of in the last 10 years. But when you think about the challenges that have been in Flint, Michigan, you know, the environment where there are underserved as far as social services, as far as investments, all of those things. These are the circumstances that, you know, I was able to see growing up on the north side of Flint. And so I was able to take that with me into my career and share that with my patients, and then be able to work together to build advocacy. But that always touched them when they could see someone who looked like them. And then we would see each other at the gas station or the grocery store or something, and they would always show me pictures of the babies and things, so you build these relationships that last.
Thank you. Dr. Burgos?
My mother came from Puerto Rico. Basically, she came from the countryside. She came in the 50s. And that was one of those waves that occurred of Puerto Ricans migrating to the mainland. She came here looking for a better life. She ended up settling in New York City, specifically Brooklyn, specifically Bushwick, which is a really, really poor neighborhood. She ended up spending her life working in factories. She was a seamstress. She worked in what we used to call sweatshops. She was a single mom, and she really hoped for the best for me. She wanted me to do better, and obviously I was able to succeed in that regard. But I do remember my mother didn't speak English, and even to this day, she really can barely speak English except for curse words when she has to defend herself. And so I remember many times going to the doctor, being her translator when she has issues, but I actually still do it today when I think about it, as well as my wife. And I remember going, to basically what were, community clinics that were quite limited in the resources they had. And we realized as I grew older that there clearly was quite a difference in the way people got health care, the way that my mother and I got health care and the way other people. As I got older and I became a physician, it was very clear to me in my practice, even though people used to talk about everybody gets treated the same, I knew that wasn't the case. I knew that clearly there were different patients that got different care. Some of it was really driven by the fact that they were knowledgeable and informed and they knew how to manage the system, and others couldn't speak the language and didn't understand how to manage the system. And part of it was, quite frankly, driven by racism or classism, where people just did not want to really treat you in a certain way if they perceived you to be in a certain way. So I think my upbringing and the way I grew up has had a great impact on everything that I have done going forward in terms of my career in healthcare.
So my story is very similar in a sense that my parents moved here and they still don't speak English. And actually both my parents, they didn't finish middle school or elementary school. And so growing up, I actually just never really had a true mentor from a personal perspective. I don't know what it's like to have grandparents. I didn't really meet them. The first time I went back to Taiwan, which is where my family was from, was to attend my grandfather's funeral. Don't really know what it's like to have aunts and uncles or cousins. But what got me into nursing was my part-time job. I worked at a coffee shop, and my assistant manager there, her name is Sarah. Many, many years ago, I'm sure she doesn't remember, but she basically took me under her wing and basically said that we're gonna find you a career that's right for you. I didn't know what I want to do. I didn't want to be a doctor. I didn't want to be a physician. I didn't want to be a lawyer. I just thought that I didn't want to follow stereotypes. But at the end of the day, she helped me figure out what I wanted, which is that I want to help people. And so she got me into nursing. And what the story is basically really wanting to tell people is that we really need to be that proactive angel for other people. It has driven my career to be a purposeful mentor that hopefully I'll speak more later on. And then the second thing that I would say that growing up, I never really entered healthcare. My provider was sleep, water, and figure it out. So before nursing school, other than maybe what's on TV, I actually never knew what a nurse or a doctor did. I actually didn't even know how insurance worked or anything like that. So I remember when I went to my first clinical practicum experience, my professor was like, okay, go. And I was like, go where? She's like, go do your thing. I'm like, I don't understand. Well, do you not know what a nurse does? I'm like, no, I actually never really talked to one before. Thankfully, that class had two professors, and of course, the other professor quickly came over and and told me that it's okay. I am here to support you. Just remember, it's okay, we are all different. So this story has led me throughout my career and my leadership journey that we really cannot judge a book by its cover. We all have our own stories to tell. Don't just assume that just because this person went into school for physician, pharmacist, nurse, that they have all the experience that you've had. Our goal is really to create that inclusive environment so that we can really teach and train future providers that's going to take care of us.
So, I'm from rural Arkansas. I'm from a town that's probably around 10,000 people. I'm the first, definitely physician in my family. I've been in the South. I'm in the South now. I practice in Dallas, Texas. So I'm a Black female OB-GYN in the South. And what many of us are describing here is the intersectionality, right? We are these many things, but I think all of those experiences that we had, you know, I had never seen a doctor of color, right, until I was pretty much probably in medical school, right? I think I may have seen one doing a summer program throughout college, but didn't grow up. Definitely didn't see that in the town and the community where I lived. Definitely not. And so, again, we're all describing intersectionality, but these experiences that we've all had, we bring to the work. And so I'm clear, while we're all connected to a system, and we're all part of that system, but our individual perspectives, experiences that we've had in the past, I know help shape the systems wherein we work. And many times I'm certain my colleagues would agree, we're that representative for all of us, right, in the settings wherein we work. So just a little bit about me, but thank you for the question.
Wonderful. And we're going to come back around to the issue of systems in a moment. But I want to, one, highlight the power of stories. And thank you all for being vulnerable and sharing a bit about your personal stories. Perhaps you can tell us a bit about how you think about the stories and narratives of others when you interact with your patients, when you interact with your learners, your students, and that was a great example that Dr. Chien just gave us. How do you help others to realize the power that they have within their own stories?
That's a great question. I think that one of the things that you can do is just stop and listen and acknowledge, ask the question, show interest that you really want to know. I think, I don't know if you mentioned you didn't have a mentor and you just went through. A lot of my life I felt that way too. And how amazing it is when that one person in that leadership position or in that position of authority or someone that you respect and admire just stops to listen and ask you about yourself. And I try so hard to do that with I haven't seen patients in a long time. I'm steeped in the science now, doing research studies, but I try to show up that way with my colleagues as we move toward building a health equity lens in the context of all of the work that we do. Who are you? And what do you bring to this work? Why are you here? And how can we use that to, and again, research tells the patient's story. And we want to be authentic and honest in telling that patient's story.
Well said.
I'm reminded of when I was doing my residency, I was at North Central Bronx, which is basically a public hospital in the Bronx, and I was during the AIDS epidemic. And the hospital was just full with patients that were really suffering from the outcomes of the socioeconomic environment in which they lived. There was an incredible amount of substance abuse, AIDS, alcoholism. And, I was probably one of maybe two Latino students, medical students. Pretty much everyone that was working in that institution on the professional side, the medical students, residents, and doctors were all. Can you hear me? Sounds like it died out. We're all basically Anglo. And I remember one night I was on call, it was very busy, and we were sort of in a back room having some food between patients. And these individuals started talking about these patients, and they were calling them all sorts of derogatory terms and what have you. And I remember I became incensed, and I basically told them, I said, listen, you need to understand something. You don't necessarily understand these people, but part of the problem is you don't even talk to them and listen to their stories, because if you did, you would find out what made them come here. And I said, but separate from that, these people are basically giving you the opportunity to learn to be great doctors, because they're giving their bodies to you for you to practice on them. And by the way, no one is even judging what's going on in this place, because this is a municipal hospital, and the guardrails maybe not there to the extent that you would expect to be occurring in the health system delivery, because that's a reality, right? And I never forgot that. I remember they just all kept quiet and looked at me like, what? They forgot that I was not actually one of them, that I was a Latino, like most of the patients that were in the hospital. So to me, I think it's always important for you to be able to carry that with you, because sometimes you make the assumption, and you shouldn't, that people are sympathetic, that people understand. A lot of people, if they don't come from the background that you come from, oftentimes they're just judgmental and just make decisions. So to me, listening to the patients, understanding them, and I remember, and even to this day, when I talk about patients, I always highlight the social determinants of health, and how those are so impactful in what's going on in their lives and what's going on with their health care. So that's how I kind of address the issue.
Yeah, powerful.
I would say this goes back to another story. So when I went to grad school the first time, my school paired me for a random practicum with the federal government. It was with the ONC under the Health and Human Services. So my preceptor was a director of one of the programs, but what my story is that the chief nurse officer at that time, she just came to me and then she's like, I'm gonna make this a meaningful experience to you. And proactively within those 4 to 6 months, she made sure that I met with every single nurse. And to this day, we still stay connected. And I had that weird question. I was like, well, I'm just a grad student. Why are you focusing so much on me? And she's like, let me correct you. You're not just a grad student. You're my colleague, and I value you for who you are. So that proactive mentorship is so important. A lot of times we're waiting for these students, or we're waiting for others to reach out to us. At the end of the day, that's not the key. So the last thing I would say is, in many conferences, we talked about the importance of mentorship, sponsorship, coaches. And one of a conference I attended a couple years ago, same discussion, everybody was inspired, and then someone from the audience stand up and said, well, you all say this is great, but I've been trying to get a mentor all my life. Where are you all? And that really, really struck me, because at the end of the day, it's like, we say all this, but are we making it easy for these mentees or people that need help? Are we creating proactive opportunities for them? So these stories have carried me. I'm starting my best to create presenting opportunity, publishing opportunity, whatever it is, together, so that we can grow together and create unified leaders together. So.
Thank you. So lifting up patient voices, I think clinicians have multiple opportunities to do that, right? So we do it in our work, day to day. I do it in staff meetings, day to day. We have the opportunity at higher levels, right, of advocacy. And so when I think about the experiences that I have, not only personally with patients and the experiences my patients have, I'm clear, they may not have proximity to power. Legislators, hospital CEOs, pharma CEOs, but I do, right? And so I take that and I bring that with me. And I think that's a personal responsibility, no matter what level you are, even in your own hospital, your own academic institution, deans, chairs, it needs to get there, and they need to hear it. And you need to be audible, and we need to be speaking on behalf of folks. And I would extend that. For me, it's even with my staff, right? So you heard me talk about the community-based organization I work with. We embed this health equity language, teaching and skill set and advocacy, even to the staff. I have 2 staff now that are in DC at HHS speaking, and I'm talking about case managers, office managers, where it's not only the responsibility, because I truly believe if you don't have everyone at every level A hospital has to think about the person at that reception desk, all the way to the nurse, to the doctor, to the chief of nursing, to the CEO. It needs to be embedded at every level. It is the only way we advance equity. Is that what we're talking about today? Advancing health equity.
That's right.
I think that's the title.
That is the title. And actually, let's continue on that note, on that tip. So each of you are leaders within your respective organizations. And there's a reason that you are here at this summit because of the work that your organizations are doing, that you are doing within your organizations. If you can tell us a bit more about the narrative, the story of your organizations as it relates to health equity and how your organizations are moving that work forward.
So again, I'm with Pfizer, and Pfizer has long had a commitment to equity. The Multicultural Health Equity Collective has been in place for over 10 years now and leading that work in the organization. But in 2019, our values for the organization changed. So our spouse values, what you see, courage, excellence, equity, and joy. That was something that was put forward for all of the colleagues in the organization. And so for those people who are doing that work, kind of as a part of a colleague resource group, working with Naisha and Melissa with the Multicultural Health Equity Collective, this unleashed the power of our people, literally to do this work around equity. So in every single space, there is someone trying to understand where is the injustice-driven disparity and inequity in our organization, and how do we alleviate that through our work? So one of the main things that I do is, again, resonating with what you said, it has to be at every level. So having every colleague have a shared understanding of what health equity is, what it is not, what are we trying to accomplish? I mentioned earlier, we're either looking for that patient to have an experience of equity, or they're going to have an outcome of equity. So what does that journey look like? Are they having an interpersonal issue when they come for healthcare, or are they having difficulty when they get to the pharmacy, or are they being treated poorly in some other space, or transportation, all the social determinants? We have to look at all of those experiences, because you can't just look at the clinical outcome. We can't just count numbers. People are not numbers. So we have to look at all of that. So how do we embed mixed methods in the studies that we do, and not just quantitative research, and make sure we bring in that patient voice? How do we pull through these concepts when you break down a job? If you're a marketing manager, what does that look like in your role? What does it look like for clinical scientists? What does it look like for procurement? We want everybody to take the work that they do and say, how do I make sure that we know where there is injustice, where there needs to be fairness? How do we pull that through? Because the patients see it, the stakeholders see it, even if you don't see it. What you put out is what you get back. We want to make sure that everything we put out at Pfizer is something that has that equity lens, our equity brand. People can see that and they say, oh, that's from Pfizer. So that's what we want, and that's what I endeavor toward.
Wonderful. And yeah, definitely that contributes to the sustainability of it as well.
So when I think, and I'm particularly going to speak about the Latino experience, basically, as you know, about 20% of the U.S. population now is Latino, which is basically 1 in every 5 Americans, and it's continuing to escalate and increase. When you look at healthcare and you look particularly at the physician levels, there's basically about 6.9% of all physicians are Latino. But if you look at leadership roles, it actually drops down to 1 to 2%. So to me, we have a fundamental problem for all the communities that are underrepresented, that are of color. First is, how do we get more people to become physicians and to become nurses and to become pharmacists, to better represent the communities that they serve? But as I mentioned to you earlier, when I was practicing medicine, I realized that I was doing the best I could, but when I looked around me, I didn't quite see everybody else making the same kind of effort. And so that drove me actually to go into leadership, to go into management. And over the last 30 years or so, I've been in senior physician leadership roles on health plans, hospitals, and medical groups. And I have to tell you, it can be very lonely being a Latino physician in any given institution. It is extremely lonely to be a Latino leader I can tell you, looking back over the 30 years that I've been doing this, I can only think about one time when there was actually another Latino executive at the same time as I was working in an organization. Those leadership roles are fundamentally important because ultimately it's at the leadership level that decisions are made that have the truest impact of all, and which basically eventually become embedded in the organization and stay with the organization. So there really is a strong need to do that. The organization that I represent, the National Hispanic Medical Association, of which I've been a member of over 20 years and been very proud to see its evolution, that has actually been one of our emphasis, is really how do we help physicians, Latino physicians, to become leaders. We have our own fellowship. We've actually had over 200 graduates over its history. And when I look back, I see many of these people have actually managed to get into positions of its leadership. I'm not saying that that fellowship by itself was responsible, but I would like to believe it helped. So to me, it is really important for us to understand that we need to be present. We have to be there, because if you're not even there, you don't really have an opportunity to make a difference. But then we need to figure out how we work our way up through leadership roles so that we have more ability to change and impact what's going on. That's one of my commitments, and I think it's the commitment of all of us here is to figure out how to be able to do that.
Hello again. So representing the Asian American Pacific Islander Nurses Association, I think a big part of organizations like this and all of our organizations is, other than the theory and other than what everyone talked about, is really being able to empower, enable, and create opportunities for people at the national level. And why do I say this? So when I was invited to speak, I don't know, about many years ago for my first keynote, I was like, no, I was so against it. I was like, little on me, I don't got no story to tell. And they're like, you do. I'm like, no, I don't. And I was very, very shocked and shy, but I was like, you know what, I'm just gonna tell my story. And whatever it is, what it is. And that was very memorable because so many people came to speak to me afterwards, and they told me that they do not see themselves because they don't see other people that look like me or look like them in these roles. So they were very shocked that they see someone that looks like me in several senior executive roles, including in the public sector, but even in the National Association. And so the bottom line is that we need to be able to pull these people, create more opportunities, empower them, let them know, like, there's nothing special about me. Each and every single one of you have a story to tell. And our organizations and the systems that we support day to day, we need to create these opportunities to empower each other, because I can't do this alone. We can't do this alone. All of us need to come so that we can really advance health equity. This is everybody's priority.
Thank you. I almost forgot the question, but I think it's
We're talking about your organization.
my
Yes.
organization. So, yes, so the National Medical Association, you all heard me state, it was formed in 1895. And so when you think of many of the minoritized medical organizations, we were formed because we were excluded from others, such as the AMA. And so we were formed out of necessity, right? And people always often ask why. But if you think back, doctors at the time, you had to have continuing medical education. And now in order to get hospital privileges, you had to be a part of the AMA, right? And so people forget this was key for career advancement. And so that's why the NMA was formed. The primary mission is the elimination of healthcare disparities. Yes, 1895, 2024, we are still talking about healthcare disparities, right? And so that is important. So that roots a lot of our work. We have 26 medical specialties, everything from aerospace, allergy and immunology, to urology, right? And these sections all work. We're divided into 6 geographic regions throughout the US. Regional chairs all work because, of course, there are some regional and geographic nuances in this country, right, that we have to deal with specifically. And we execute the work. We have a House of Delegates. There's policy-making body. We have fellowships right now. Climate Health Equity, our Chef Fellowship, is doing some really great work. Violence is a key component for us, right? ACEs, all of these things that we are working on that are either health disparities or are contributing to ongoing disparities in this country. And so I would say that in thinking about the work of the organization, the work I've had to do over this past year, of course I'm an OBGYN, so of course I'm gonna lead with maternal and infant health, but also really women's health for me, right? Women's health. Cardiovascular disease in women is very important to me. It's pervasive throughout my own family, but also when you look at the disparities, and almost 60% of Black women over the age of 21 have cardiovascular disease, some form, right? So plenty of work to be done, because I think many clinicians in this room would agree with me, when we can prevent premature death and disability, especially when it's preventable. And so it's quite challenging being a physician when you constantly see people who are dying who didn't have to, people who are disabled and suffering who don't have to. And so that's what drives and leads me. And then lastly, I say the reason for all of our existence and why it's so important is because we want to inform policy. It is very important that people are not ideating about we either as minoritized doctors and nurses need, but also the communities we serve, what they need. People are not ideating about that, but we are informing them, because what I have fought against over this last year and have fought against previously in all my other leadership roles and will continue to fight against are people forming policy that is bad policy, that's not applicable, and that is not embedding equity.
Well, actually, Dr. Lawson, if you hold on to the microphone, I would love to stay on the topic of policy, because we've talked about ourselves, we've talked about others, our organizations. What about the systems that we're a part of and the policies, the practices that govern those systems? If you can share a bit more about the policy work that you've been involved in and or how we can help to mobilize communities to impact policy.
Absolutely. So personally, the policy I'm involved in and on behalf of the organization, so there were 3 pillars I was highly focused on, and the one was really the healthcare workforce and the diversification of the workforce, ensuring that also preservation of the workforce. So I'm thinking about it in a couple of sectors, because it is challenging for our minoritized and marginalized physicians, nurses, pharmacists, all of that in the workforce. So I did a lot of collaborative work over the last year, meeting with Congress, but taking my colleagues with me, taking Black nutritionists with me, pharmacists, the president of the Black nurses, like all bringing people with me, Black lawyers, like everybody, because I know, I remembered is my mother told me there's power in numbers. I grew up and my mother told me that. And so that's that collaboration piece that I think is so important. So workforce was important. I testified before the Senate Health Committee around this fact, not only the workforce, the diversity, funding our HBCU medical institutions, funding and resources around the maternal health disparities. All of these things are so important. But what I bring with me on every opportunity are the patient stories, right? So that doesn't matter if I was speaking before the FDA or whomever. It was bringing those patient stories, making it real, making sure I framed these are real people. These are not just numbers. These are real people that we know and we have to face day to day, right? And help navigate them through their challenges.
Thank you. Dr. Chien?
Because of my day job, I will keep it a little bit more brief. I will say Civics 101 is very important. I've learned that a lot of people don't understand. So understand the power of advocacy and how you can influence policy. Your voice does matter. And if you don't have a seat at a table, create one. So I would say, your voice matters. And then the second thing is I can talk more about is organizational policy is just as important. So whether it's organizational or departmental policy, there's a lot of room to advance health equity. Every word does matter. Even just this morning, we were talking about it, and we have physicians here, but there's a lot of policies from maybe many decades ago. Instead of saying maybe a more inclusive, like a healthcare provider or staff, it may just say physician. And so that's just an example where sometimes one word can help make things more inclusive for the agenda or the goals that you're trying to advance. So the power of speaking up, even if it's just a little section, can really help influence change.
Wonderful. Thank you.
So I think, we're at a point in time where I think it is generally accepted by most everyone that social determinants of health are a major impact on people's health, broadly across to all Americans, irrespective of your race. The challenge, though, is that when you look at certain populations, the burden of social determinants of health is extremely high. To me, looking at the Latino community, language, the inability to speak the language, lack of health insurance, significant issues of people being able to get health insurance, not knowing how to navigate the system, poverty. All of these things have a significant impact on how people are able to take care of themselves and maintain their health. So from my perspective, as we look at things like, for example, the recent decision by the Supreme Court around race-based admissions, I think we need to understand that not everybody in this country is the same. I think most of us in this room know this one, but somehow it escapes a certain part of the population of the United States. We're not all playing with the same set, a deck of cards. And so for us, at the National Hispanic Medical Association, we keep coming back to the fact that just looking at the population, looking at people, there is just incredible disparities in terms of people's access to the things that are basic that would allow them to have healthy lives. And so therefore, a lot of our focus is around that. And that then in turn ties back to things like, how do you address this issue around the decision of the Supreme Court, and how do we best try to support our students that are looking to try to get into medical school, for example, how to navigate that. Or to the extent that we look at different policies that may have a negative impact by virtue of taking access to health care or support. Because the people that suffer from that are not the people that are working and have insurance, it's the people that don't have it, right? So I think we evolve as the environment that we're working on evolves, but the issues are always the same. We're just using different words to try to get through it. But as someone asked me recently about, and I don't have the limitations you do, about politics and how would our organization be affected. I said, well, the way I look at it, if it happens one way, our life will probably be a little bit easier and we might be able to get things done a little bit faster. If it happens another way, it's sure good that we're here to fight the battle. So either way, we're not going anywhere. We're gonna still continue to be fighting and pushing forward. And that's kind of where I think the NHMA comes from, and I think that's a lot of organizations like the ones that are here. We know we have to be here. We have to be present no matter what happens.
I want to clap too, but I want to talk.
Yeah,
So many things that my panel members that you said really resonated with me. A wise professor once told me that all policy is health policy, so we have to look at everything in our environments and understand how those things are impacting our patient outcomes. And I think about institutional policy, how important that is. One of my remits is to look at policies, processes, procedures in our organization and understand how inequity may be working there, and then how we may be able to make changes. But my role in particular actually sits in the policy group in vaccines. And a huge part of our remit is to make sure that there's the optimal recommendation for our vaccine assets so that patients who are eligible can receive them when they need them. One of the things that, there was an equity piece or domain that was added to that evaluation process for vaccines in October of 2020. And that was in response to the COVID pandemic, and it has been ongoing. It wasn't there previously. It was kind of embedded in the other domains, but equity was pulled out. And so one of the things that my team was able to do was do an analysis of how that equity domain was implemented to understand if there are opportunities for the folks who are responsible for determining if there's going to be an impact on an equitable outcome or experience for patients. How different are their judgments when they look at this particular domain versus others? And we were able to present that at the National Immunization Conference, and that's an opportunity for us to raise that. There was a difference the equity domain had more variability in those judgments than the other domains, looking at is it a public health problem, looking at cost effectiveness, et cetera. We also found that the values domain had a little bit more heterogeneity in those judgments, and those are things that are more on the social science side, the social determinant side. So there's an opportunity to have a conversation now about how do we think about, how do we understand what's really happening with those patients. The meeting that for recommendations is actually happening as we speak right now. And I'll tell you, those are available on YouTube. They're open to the public. This is all public information. But when you look at how that equity domain is presented, you see those numbers, but you don't hear the story. And so we want to make sure that we want to lift that and start to have those conversations. And then I'll just share something that happened to me recently. Again, my remit is research. And one of the things that we need to do is not, we have a conclusion when you have a paper. There's a conclusion, there's discussion, but you want to make sure that you have conclusions and discussions that can be used by the people who are making policy decisions. Someone told me, oh, just let the data speak for itself. The data never speaks for itself. Every single one of us, we all basically gave our positionality statements today on who we are and how we came to be. And that is, everyone has a positionality, and that is what is being interpreted in those discussions, in those conclusions. And so it's incumbent upon us to make sure that we provide direction for those policymakers so they know how to use those data that we're generating when we have that health equity lens. So that is the core of what I'm doing around policy, and just encouraging everyone, even if your role is to educate patients, I'm just going out and providing education. A part of that education can be, okay, here are the facts, here are the outcomes, here's what you can do, but raise the bar on that, what you can do. How can I advocate for myself with my provider, with the payer, with the institution where I seek my care, and we raise that again with the physicians in their spaces, come together. It may come up, but Power to Heal,
Yes.
I saw that at NMA. That moved me. If you haven't seen Power to Heal yet, it's a documentary on how physicians, particularly Black physicians, the NMA, were really pivotal in a huge policy, the Medicare, for the implementation of Medicare, here in the United States. And so that is a picture of what it could really be like. We can really make change. We can really make change. So, thank you.
Well, we'll open it up in a moment to our audience, both in person and online, for questions. But while they think of their questions, would love just some final thoughts, some closing thoughts from our panelists, starting first with Dr. Lawson.
Certainly. I just, you just brought up data. And so when I became president last year, the first one of the first speaking engagements was in Puerto Rico. And I was at a meeting of Black and brown folks, and I just pervasively in the audience, the room is full, and I'm hearing them talk about data and how it's used against us. And they were in the audience talking, and I'm sitting here horrified, right? I'm a physician scientist, so we need data for everything. I can't get any money. I can't get I can't do anything without it. And so I really began to work over the year thinking about the context of that. The context of that for Black and brown communities, if that's where but how do we apply that? We need to know that, because that matters how we approach them. So I'm really happy to hear that you brought that up, because it's very important for us to all understand how the community sees data as necessarily bad, but we see it as good. But again, really happy to be included in this conversation. I always enjoy this level of talk. One of my newer roles for my day job is health equity also. And so really definitely in the payment space, looking at I just was working on maternal birth pay equity, right? For maternal health care providers. So I think there are so many ways that we can do this. There are so many aspects of health equity that we can all engage in. And in this country and in our roles wherever you are. And so I just encourage everyone to join us in trying to make this a better country.
Hi. I would say that the biggest piece that is very important is that we, as minorities or as whatever group you want to call yourself, we within ourselves also have a lot of segregation or whatever you call it, competition and things like that. And we gotta acknowledge that. Like, none of the people that have helped me looked like me. And so I'm very thankful to them, but it's, it's just a sad truth. And so it's one of those things that we really need to be unified, even within our communities. It doesn't matter if it's professions, doctors, nurses, pharmacists, who you are, or where you're from, or how you grew up. We need to come together so that we can really make change. Because bottom line, one of the doctors that have told me is that it doesn't matter, your positions, your job, your organization is gonna change. I'm sure many of us have been. And yes, not telling you not to work hard. Obviously work hard in the duties that you do every day. But at the end of the day, do you wanna be remembered by the organization, the position you worked in, or who you are and the legacy that you leave behind? So that's a hard question. It's probably $1 million question, but what is the story you wanna tell? And how can your own actions really bring about change? Because it's always easier to change yourself than to expect others to change. So that's the motto that I follow.
So I wanted to follow up on the comment that you just made about that people say, let the data speak for itself. Well, you're absolutely right. The data can't speak for itself. But the problem is we live in a time now where depending on who is talking about the data means something different. We live in a world of alternate realities. So now 1 + 1 can equal 2, but 1 + 1 can equal 3, 1 + 1 can equal 4. It all depends on how you feel about it. That's very dangerous. We have a responsibility to speak against that. They say that 90% of success is showing up. We all have to show up. When these issues come about, we have to show up. At a minimum, we have to show up. And then hopefully we need to speak up. I think it is very important for us to realize that we are the ones that make a difference. I know earlier today we were listening and there were conversations being directed at our high school students and our college students. I actually found it very inspiring to listen to some of the things that we're saying because they are the future, right? Mm-hmm. But we are the present now, and we have to make sure that we have a future for them. And so therefore, it is really our responsibility to show up, to speak up, and to try as best as we can to be the light that is needed.
I love that, showing up and speaking up. I think one of the things that I would like to leave folks with is that when you're in a role of leadership or just any space, you don't have to be in a leadership role, create a space of psychological safety so people can share and talk and learn and grow. That doesn't mean comfort, because comfort doesn't bring you to change, but psychological safety so people can really share with you what they endeavor to be, what they endeavor to do, those mentees, those patients. And then also, just for the panelists, I want to just say that thank you for being, allies, accomplices, all the things, because we need that. So be that to someone else. Those are the things that really resonate with me, and I want to just leave the audience with today, to be that space to allow folks to grow and flourish, so that we have physicians of color, we have nurses of color, even those of us with late chronotypes. That's an inside joke. But definitely we want to make sure that we're encouraging that next generation. There are a lot of headwinds out here, but we can stand in the gap for people and really move health equity forward.
Wonderful. Well, we'd love to work to open it up to our audience in person. Are there any questions, any reflections from what you've heard today? And please feel free to come up to the microphone and introduce yourself.
Thank you all so much. Naisha Foster, Vice President, Global Health and Social Impact at Pfizer, and I have the great honor of co-leading the Multicultural Health Equity Collective, which along with Morehouse School of Medicine and others were the co-conveners for today's discussion. And so my question really is, as you sat here and listened to each other, was there anything that you heard that you want to follow up with each other afterward? One of the reasons we have this conference is not only to educate, but to make sure we have some calls to action and that we're pulling people together who are in this fight and want to fight together. Curious as you listen to each other, what could you all do together tomorrow, next day? Thank you.
That's a good question.
I'll start. I'm the master collaborator. I believe in that. So Dr. Burgos and I had a call before we even got here, last month maybe, and we have another one next week. I got to put on your calendar. So I think there's a lot of work. I mean, so the under the auspices of the AMA, they call us the Marginalized Medical Society, as I still struggle with the word, but we meet on a quarterly basis. And some of that work, and Dr. Burgess, I've been on there a little bit longer than you, but some of that work is really aligning where do we all mutually land? What are those things we should be working on, collectively? And so, I started tracking as we would do this work, we would have these meetings, and a few years ago, workforce was high, but really it was around safety in the workforce for healthcare providers, right? So I'm thinking about just the diversity. Safety was an issue. I live in Dallas. You all remember a gentleman walked into labor and delivery and killed labor and delivery nurse. So we've had multiple of our Black physicians murdered at work. And so that was something that really struck me. And so that collaboration drives us to get to specificity, right, around policy work that we mutually agree. And then secondly, of course, with NHMA and others, the workforce and medical school admissions, the diversity, especially after the Supreme Court's decision, and the ripple effects of that, right? The ripple effects. While those were undergraduate institutions, we were already seeing those impacts from medical education. So I would just leave you with that.
I would just say, in the last several years with the pandemic, it has taught us anything is possible if we work together. I mean, I know nowadays maybe different organizations are trying to say that didn't happen, but anyways, it does work, so continue to do that. And that includes representing Asian American Pacific Nurses, Islander Nurses Association. Different associations can also work together.
That's right.
Shouldn't be just only the nurses work together or the physicians work together, and we're starting to. But it's one of those things, I think there's opportunities. If we come together as a space, we can make actions happen, just like what we did during the pandemic. We made change and we made improvements.
So I would echo what has already been said. Obviously, it is really fundamentally important for all groups that have a common interest to come together and work together. And I think it's also important for organizations such as Pfizer, for example, to try to facilitate that kind of activity. I can tell you right now, I'm working with the AMA on a project where they're trying to address, to your point, issues around the history of AMA. I remember when they approached me in my new role and they said, will you want to sign a document to participate in this? I said, well, I'll be quite frank with you. When I finished my training, I joined AMA and I paid AMA dues for quite a number of years. At some point, it got really expensive and I couldn't really figure out why I should be paying the AMA this kind of money. I said, quite honestly, I concluded that this organization primarily exists to support middle-aged white guys, and that's not me, so I'm really not that interested. I think they were taken a little back, but they realized that that's for the fundamental problem. I told them, listen, no matter what you do, 20% of the population of the patients that your doctors will be taking care of are Latino. You're gonna have to deal with that one way or the other. And I said, so if you wanna talk about that, I'm willing to talk about that. And so they're trying to bring together the different groups as well, and I will participate in that because to the extent that we can do something together and collaborate, I'm all for it.
And so I think just before we came in, we were talking about how can we work together more closely. So Dr. Conwell and I were talking about that. Specifically, the Multicultural Health Equity Collective has again been in place for a number of years. So how can all of the groups at Pfizer start to understand how they can work more closely with the collective and internal consortium? And then as I sit here today, I hear some we have some things in common, and so there's some other consortium activity. We can identify those things that we really are focused on. There's some workforce development things, of course. We were able to establish the first Doctor of Public Health Fellowship, Pharma Fellowship, in 2022. Our first cohort just finished this year.
Wow.
And you usually see pharmacy students, and you'll see opportunities for physicians, but to have Doctor of Public Health students come into biopharma and bring that public health practitioner lens at the doctoral level, so that when they're finished, they're qualified to come in and lead and help make decisions and understand that policy that we all talk about and make that impact. So so many things that we can do together. So I'll be in all the inboxes. I have your email.
So I think we have another question.
Hello, thank you again for all the wonderful panelists, and I'm so glad that we have an Asian on the panel, because every time when I went to a health equity kind of conference, we're not there. We're not. So my name is Chien Huang. I'm an immigrant from Taiwan, and for the past 10 years, I was the founder and executive director of Asian Women for Health, a nonprofit organization in Massachusetts. And so, well, first of all, I really, really appreciate this, the organizer bringing this summit together. But I would like to see the name of this this session to change to the role medical professionals play, because obviously, you are not all doctors, right? We have nurses, we have public health officials, and all that. And my question is, so I'm going to tell a quick story. So I serve on a national board for an organization. And so I always, advocate and wanted to, lift up my community voice. So I mentioned a couple times in that question, I said that why we don't see many more person of color, serve on this national board. And I got pushback, and I was pulled aside, and they said that, why are you playing the race card, and we value more of diversity of thoughts than, the skin of color. So I guess that's my question, is that how would you respond to a question like that, and how can you make sure that, yes, we want to create a pipeline of future leaders, but how can we not fall in the track by, just electing somebody and put them in a leadership role, but then they don't have the real power to make change, and they only serve as a token, and only serve for the organization to make a check mark on they fulfill the DEI obligation.
Wow, so that's potentially a can of worms that I do think we need to wrestle with. I want to open it up to the panel, because I know we actually have kind of broached this even before the panel discussion. Would anyone like to address that?
I'm in Texas, okay? So, I wake up every day navigating. I navigate how I'm gonna wear my hair, what I'm gonna wear. I navigate every single thing. But the one thing I think for me, I can just personally say, I still sit on boards where I'm the only, I sit on a city board, hospital board, and I would speak to you and say, your representation matters. And your representation matters because you have the courage to speak up, right, to what you could visibly see. And it's difficult to be that person, but I'm that person a lot. I'm in a lot of rooms where I have to be that person, and have to be that person to make sure everyone understands this homogenous room, I'm gonna use the word homogenous, cannot figure out the problems for poor and black and brown people, when none of you are that in this room. So I walk in a lot of rooms where that's what's going on, right? And I have to speak up constantly. And you do begin to feel like, you begin to feel the weight of that, of always having to advocate. But it's so important that we be that and do that when we have those opportunities. And sometimes it really may work. It may take you asking that question 3 or 4 or 5 years. There have been places, right? It may take that, But I still believe you must continue to have the courage to continue to speak up. Call it out when you see it. Call it out and make sure that people know that you're watching. And I'll give you some other tips when I'm not on the mic.
And with that, please join me in thanking our panelists.